Thank you so much for your kind introduction, and thanks to everybody who is joining us today. And I think this is, I want to thank Lung Cancer Canada to start this initiative. I think as we go forward, we would like to, I think, get input from people here to see what they would want to know and how that should shape, like if these kind of meetings would be useful. And I think a lot of things would also be to how you can get information about other things and also touch base with and meet other people who are in the same kind of journey and caregivers and tap on. Unfortunately, I wanted to see more of our psychosocial, our support group, other people who we are missing today. But I think that would be very helpful because this is truly a multidisciplinary, and I think this is our first meeting, but I would have maybe this is my suggestion to Lung Cancer Canada, that I think we should invite, and not just medical oncology. I think we should also invite radiation oncologists, surgeons, respirologists. And if you tap into me and let me know, we have a good team. We have an excellent team here in Saskatoon, where we have a good multidisciplinary team, actually. I would have really liked to have my colleagues here to speak on different aspects, because medical oncology is only one part of how we want to manage this. So the topic I was asked to talk about new treatments in lung cancer. So it's very it's getting vast, because I think good in a way, because it's new developments happening every day, and the things are coming fast and furious every coming year. And there has been more developments in the last 5-6 years, I would say, than they have happened in the last like 10, 15, 20, 30 years. So there are more developments happening in management of lung cancer and all other cancers. So for today's purposes, what I want to give you an idea now, I didn't go and I put these slides different, picked up from different presentations and put it together to give you an idea about what has changed, what is new in the lung cancer field, which has happened in the last 4, 5, 6 years. And I think some of these slides are really, these are my disclosures. Some of these slides are technical, but I would want to just point it to you, and I don't want you to get lost in the slides, but I want to just give you an idea. This is just to give you an idea what is new happening in this area, and go from there. So and this is quite a broad field too. So I'll kind of give more of a summary perspective in this. So I'll tell you what are the types of lung cancer. You might have heard what is biomarkers, and then what are the newer types in different kind of lung cancer. What something is called non-small cell, and then there's something we call biomarkers or driver mutations, and then there is a more aggressive type of lung cancer, small cell lung cancer. What has happened in that area? So so why is this important? Because lung cancer is a big menace. It's a major health problem. And as you could see, most common cancer, one of the most common cancer in Canada. I think we don't have a pointer. I don't know if this will work. Yeah, I'll just point your attention with this. So you could see close to 32,000 patients diagnosed 2022. And it's a high mortality rate with that. We lose more people from lung cancer than the breast, pancreatic, colorectal combined. So major problem. When we talk about lung cancer, there are mostly two types of lung cancer, what we speak. One is called the small cell lung cancer, which is a more aggressive type. Fortunately, it's not that common, and the incidence going down. So around 80-85% is non-small cell, and then about 15% around small cell. It depends on which patient population you look. Some places is more than other. This is overall picture. This one is very closely associated with smoking. And as you could see, between both cancer, most of the people present with a stage 4 or advanced disease. So that's a major concern, because then you can't cure these cancers because they are in advanced stage. For with this, and I think Michelle was trying to get somebody from the screening to talk about screening. I don't know if she couldn't get the speaker was supposed to come and speak about screening. And hopefully, once you have lung cancer screening, then this will go down because you're catching the cancers early on and then possibly cure them. Uh, so that's the hope with the cancer screening. And talking about non-small cell lung cancer, so non-small lung cancer is basically also divided into different kinds. The pathologist will look under the microscope, do a bunch of tests, and tell us what kind it is. More common ones are called adenocarcinomas, and then less common squamous, and there are other types as well. And then when you look at adenocarcinomas by itself, we have a lot of research in looking something called biomarkers. That's what biomarkers are. They're looking into what genetics is driving those cancers. And when you look at these adenocarcinomas, they are not all the same. You could see they are driven by different things. There are different mutation, different alteration happening in these cancer cells, and they would be driven by those different um, alterations, and that will drive a different path for each of them, and their management would be different a bit, because we were giving all these cancer chemotherapy. Then now with the finding of these alterations, we know that you can target these mutations and hit the cancer harder than just giving blanket chemotherapy. And so you could see there are different variations of these mutations. The common ones like EGFR mutation, which was the percentage depend, where you look. You go to China or East Asia, you will find this EGFR mutation way higher because it's common. Actually, in East Asian, it's common in non-smoking or non-smoker population, in women. So it's a which area looking. You have high EGFR mutation if you go to Vancouver area, while in Saskatchewan or other places, we don't have that kind of high EGFR mutations. It all depends which geographical location you're looking at, what mutations. Similar about ALK mutations, and then a whole bunch of different kind of mutations. And we still don't know about close to 30% what kind of mutations there are, but there are new mutations being found every day. Yeah, very good question. So what happens is when you treat with certain drug for a particular type of cancer, and they may be driven by a particular mutation. And when you target that, so after a while, these cancer cells become smart and they try to get around the reason why you're suppressing them, and they can evolve into a different kind of mutation or completely get off path by different kind of growing mechanisms. So that's something called resistance patterns, and that happens in pretty much all cancers, and that's why we can't cure them, because as you suppress one particular clone, and then there's a different type of EGFR mutation may happen, or they develop into a different pathway and find a way to grow. So, and checking these mutations or alterations, they are called molecular testing and or biomarkers, as we call them. And this is pretty much now recommended as a standard to test all these particular mutation and some of the evolving ones, so that you can target. Nowadays, it's a standard of care. Patients should have, ideally, these patients, before you see a medical oncologist, should have all these mutations available so that they can make a very informed treatment decision. And fortunately, in our province, I shouldn't say province because, a little bit Regina does go separately, and Saskatoon and up north, it goes to Saskatoon. But we made this decision to do reflexly. So we used to, every time the report will come and the medical oncologist or somebody will request, now we made that decision initially that any lung cancer and the pathologist could automatically go and test it. So we're not wasting time. And I think we made the decision a few years ago and it's paying off because now we require mutation pretty much all stages. In the past, we needed it mainly for stage 4, but now we need it early as well. And why is that so important? Because here you could see that almost like 50% of these non-small cell lung cancers have some kind of targetable mutations. What does it mean? So as you could see for EGFR, and now these are not EGFR, there are a lot of type of EGR mutations, but there are particular types where you can find there's so many drugs which show benefit. So initial trial, so how it starts is we were used to give chemotherapy before. Then we looked at these drugs which are targeting these mutations and found they are better than chemotherapy. Then new generation of drugs come, and we found that okay, they are better than even the older one, and that's how the new developments keeps happening, and we are getting into newer and newer generation of medication which are better selective to target these particular types. And that has similarly happened with a lot of other mutations like EGFR, ALK, and you could see, I don't want to name each of them, but you could see there are so many drugs now getting evolved. Some of them are available or funded, some may still not be funded, and there are areas where new developments or drugs are being tested in different kind of mutations. So again, I think this just goes on to say how important it is to have these biomarker tested to find the right or get the right treatment to the right patient, right tumor type, and is recommended by all these various association and organization. Yeah, very good question. I think it varies. So guidelines are there only to give you a guidance, and there are places where guidance are updated more frequently. But irrespective, I think right now the way the things move, we're not like, if the treatment is available, we know there is a data. I don't think we're waiting for any guideline. The practice may be a little bit different if you compare US versus in Canada, because in US, once the drug is approved by FDA and it's funded, you could just use next day. They presented in the meeting, drug is approved, you could start using. While here, once the drug even is approved by Health Canada, it has to go through certain, because we have a different system of payments and how the drugs are funded by the provinces. It goes through multiple levels of regulatory approvals before the drug could be available to the patient. However, once the drug is health cover approved, it could be used, but may not be funded still. Yeah. So there's another important consideration is the biopsies, and that's where I wanted my other colleagues, in my multidisciplinary team, our respirologists, our surgeons, if they were here, they could speak a little bit more on the challenges of the biopsy. And we stress this point of adequate tissue. Sometimes you not have enough tissue, and it's hard to go back and get the biopsy because a lot of challenges and complications to do an invasive procedure, but it is important to have a good tissue so that we could test all this besides diagnosis and biomarkers. And most of the people now understand the importance of these biomarkers and try to get adequate tissue. And pathologists are also very now aware that they want to preserve and save enough tissue to get the biomarkers done. And this is now another area where we're not implementing currently, but it's there, that is called liquid biopsy. Means you can do a blood test and do all these biomarker on the blood, because sometimes the tumors will shed these mutation or these cancer cells in the blood, and you can test out of the blood. So we don't, if where we can't get the tissue or the biopsy, you could still do on the blood. And I think that is something one of the companies is trying to support this program, and maybe we might soon have this available. It's not widely available though. So just having said about these different mutations, I'll just go over quickly about various mutations. What is new in these areas? So these are some of the approved drugs in EGFR mutation. Osimertinib has found to be really better than the other older generation, and we commonly use it. And something recently we found that that if you add chemotherapy to this osimertinib, the cancer could be controlled a little longer than just osimertinib alone. We're still, the data is still maturing whether they can. That's interesting. Something must have got disconnected. Oh, that's a two-screen thing. Okay, so your projector sleep. I went to sleep. Okay. I thought the computer is on. Okay. So I just want to stop and are things making sense, or I'm on a rant? Yeah, okay. And I put these slides, but I no way I want to go over these graphs and figures. My point here is just that it's just telling that we're trying to see what we can improve to improve the outcomes. And there are new treatments every time. So this is another example. There was another study which is looking in the same patient population where you could add another kind of antibody. It's called amivantamab, and other type of oral drug, and then combine them. You get a similar kind of advantage than osimertinib alone. Yeah, it's hard. So we can't cure because you find, there is a ways the cancer gets around and grows. And that's why we are not able to cure once you're stage 4 kind of, or we still rely heavily on surgery or radical radiation, on some other steps when they're early on to cure. It does what we were able to do in all these treatments. What I'm showing is that you can extend people's life by slowing the cancer and then hitting again, or cutting down the growth in different ways, even after So sometimes they are on treatment, and you might need to go a certain type of radiation or surgery. So there are different kind of approaches people might take. The goal is to let the cancer not grow and let people live longer. That's the goal. Whether we'll find cure, I don't know. Maybe we'll have to find a different kind of approach. I think that's where we are heading. I think in somewhere in the immunotherapy world, where the patients are living longer, even when they're not on treatment, their cancer is controlled. So the similar thing in the same patient group where EGFR mutation, but if they had surgery done, and after surgery, we used to give chemotherapy, but when you add this osimertinib, it was found that it controlled the cancer way better or longer. And as you can see here, um, you know, more than 75% better than osimertinib alone after surgery. So in controlling the cancer longer. So you could see the steps going forward in improving outcomes in cancer, controlling cancer longer and improving survival. This another area of development was where the patients with the same kind of mutation where they can't have surgery, but they would usually go with radiation and chemotherapy. And then that was the treatment, main treatment. And most of the time, immunotherapy don't work for these, so they wouldn't get anything else. And when this osimertinib was added after the treatment as a maintenance treatment, again, it was a significant, where's my cursor, improvement, around 85% improvement in patients' cancer being controlled compared to no treatment after chemoradiation. So some of these are significant improvement in giving longer control to the cancer with these treatments. And there's another type of mutation called ALK, a rearrangement, different kind of, it's not mutation, but the how the chromosome rearrangement happens. And there was really a landmark changes similar to EGFR. These treatments just revolutionized the management and the outcome for these patients. It started out same with the story, looking at crizotinib, the first drug, and it was better than chemotherapy. And then over time, there have been development in new drugs, multiple of them, and we found some are better than other. And there was a study recently looked at the drug called lorlatinib, and as you could see now, we're looking at 5 years. And this is very effective in brain because these cancers go very commonly to brain. And this crizotinib, so this was not placebo. You could see there are only 20, at 5 years, only 21% chance of the cancer not going to the brain, but with this drug, about 92% chance that it won't go to the brain. So it's remarkable improvement. It prevents the cancer, the drug going to the brain. No, the drug, sorry, the cancer going to the brain. So similarly, it happened in the same mutation if the patient had surgery and they went to get this drug compared to just chemo alone. Then you could see that similar kind of benefit, around 75% better in controlling the cancer than the chemotherapy. And this approach has been looked into different kind of, this is another type of mutation, KRAS G12C. We actually just had a trial which we closed, and these are the drugs which have been used, sotorasib, adagrasib, but there are trials ongoing. Once the chemo didn't work, now the trials are going up front where you could use with the chemo or immunotherapy right at the beginning. So several trials. We actually at our center, we have a trial ongoing now. What happens when you don't have these driver mutations, what we call the driver mutation, what if I didn't explain early, why it's called driver mutation, because that's the one driving the cancer growth. So that's the alteration which has happened in the cancer cell and driving the growth. What if we don't have or don't find these driver mutation? Then usually then we used to give chemotherapy, but in the last several years, we found that immunotherapy has really changed the outcome for the patients if we either add chemotherapy to immunotherapy or we give immunotherapy alone, and based on a marker we call PDL1. So this is something to just show. You don't have to go in detail, but for both these squamous and or in the non-small cell lung cancer, we have found immunotherapy have worked fairly well in prolonging outcome and survival for the patients. The immunotherapy has also been looked at giving early on. So, and our surgical colleagues are very enthusiastic about this approach, because in the past where the cancer was just localized, they would just go for surgery first and then deal with if the cancer is there or taken out completely and go for more chemotherapy. But now what we have several studies looking, and we're giving chemotherapy and immunotherapy even before surgery. And that has shown that is remarkable. Even about 25%, you can't see the tumor afterwards and when the surgery is done. And surgery is much easier, and it does improve the control. And there are some studies showing that it improves the survival. So if you give chemo and immunotherapy first and then go for surgery, and maybe probably able to give more chemo or immunotherapy. So that's something called neoadjuvant or perioperative. And there have been these new approaches being looked at this time. We are already doing this chemo and immunotherapy before, and these treatments are available now. Similarly, about after surgery, we would give chemotherapy, but now some of the studies have already shown that if you add immunotherapy after chemotherapy, that also improves the outcome and longer tumor control. So different kind of trials happening, different kind of immunotherapies, which had shown advantage in this situation. So now I was just talking all this about non-small cell lung cancer. I'm just going to talk a little bit about small cell lung cancer, where nothing changed in the last 30 years. Very bad cancer because it grows faster. The only lining in this whole treatment is that it responds very well to surgery. If you give chemo, it responds very well. The tumor just shrinks and melts very quickly, but it comes back very quickly. And that's a bad part about this cancer. So what we have found, it has made some steps, small steps, but it made a major impact when we added immunotherapy to chemotherapy, and it showed that it could control that. In some patients, it could control it for much longer, that response is maintained. Radiation is used in this situation as well. So these are the two studies which looked at giving something called durvalumab with the chemotherapy, and then or just the chemotherapy alone. And we found that it controls the cancer longer, and if we add immunotherapy with the chemotherapy. And this is another immunotherapy which looked in the same way and found about the same kind of advantage with adding immunotherapy. What was just was very dramatic benefit we saw in the same cancer was localized to lung. These usually would be treated with chemotherapy and radiation at the same time, because they have not spread elsewhere, and they would be usually treated with chemotherapy, radiation. And in this study, when these cancers after treatment, we would have stopped all treatments and followed up just with imaging. But in the study, when they added immunotherapy, and there was another placebo control they found significant improvement. So you could see the people living almost 2 years longer with who got immunotherapy compared to placebo or no treatment. So remarkable improvement in this field as well. And this is a very exciting area, is where some newer drugs being developed, and this is ongoing in trials. But based on just the efficacy of this, this has been approved by FDA and is being by US. And we were very fortunate. I was just very fortunate to get for a couple of my patients from, we asked the drug company, they were allowed it. We had to go through Health Canada and everything, but they allowed to get the drug. And I found great advantage to this medication. So it is using kind of targeting the immune cells and the cancer cells and trying to bring them together and causing cancer cell destruction. So it's still an area of development, a lot of trials going on this field, but a lot of new things happening in lung cancer world. So thank you. Sure.
Thank you. I'm just wondering, is there any research on immunotherapy?
Yeah, there have been trials where they looked at using immunotherapy in EGFR. Most of the trial didn't show benefit. They're looking at adding some kind of, the latest one was using something called VEGF inhibitors with immunotherapy that showed maybe there may be some advantage, but most of the studies showed that these cancers do not really, the immunotherapies don't work for majority of these cancers. So we don't use immunotherapy for EGFR or ALK. The first treatment are usually targeted treatments. Okay, Michelle, is there? Okay, thank you so much. So any other questions? Or? Okay, yeah, sure.
I'm sorry. I was wondering, first of all, the research that you covered, are there certain research and working?
So so if you're talking about Canada, I think every center has, we don't have separate lung or department. We have now group of people who do mainly lung or different kind of cancers. And I think similar in other centers across Canada, they have same group of people who would work. I don't think it's just specific lung, but they would have all the trials for lung cancer. They would have multidisciplinary team geared towards lung cancer. So there are departments who would just have lung cancer as their main. I mean, we're talking of bigger centers, especially you're looking at Toronto and maybe some other centers, BC, but it's a part of other cancer. But in US, they may have much more clinical trials than we may have. And just the availability of different clinical trials. There are sites where you could look up what trials are open where. And I think we may have some resources. I don't know if you have resources across Canada. There may be something. There's a clinicaltrials.gov where they actually, they will, if their trial is registered, it can even tell you what are the trials open in Canada. It's a US organization, clinical trials organization, but they list all the trials and what area you're looking, what stage you're looking, and they can tell you. Yeah.
Just to follow up that, if you're a patient, like, is it up to you to go to the
Yeah. Yeah, very good question. I think so. What happens is It depends on the wishes. So clinical trials, I have to say, like if it's available at your center or somewhere you could just easily go, these they follow a particular cookbook type rest. Like, you know, you have to have a scan, you have to within certain days you these much of blood test or, you know, treatment, you have to be there, and it requires your presence quite frequent. So if you say I want to do a trial at a certain center, then pretty much you have to be prepared to go to that place if it is not in your city. So that's one. Second thing is, if it is nothing is available in this setting, most of the time, I think in, for example, somebody is just newly diagnosed and there's a standard of care, there's a treatment which works. Would they want to go on that versus going on a clinical trial somewhere else? That's a challenge. I think if the patient said, no, I would want to go on a trial, then we would certainly find out a trial for them and try to advise them where the trial could be. But most of the time what happens is when you have a cancer which you want to get treated, you don't want to waste time, you get things rolling. And yeah, but down the line, I think there are definitely opportunities where you're looking, if this doesn't work, where I can go, what might be trial options would be. And that's the area where I think I would be, you know, happy to help people where depending on their wishes. Some patients would not prefer just because of the quality, and a lot of everything else comes with it because, you know, the care, other family members, there are a lot of things around it. All right, thank you.
Thank you very much, Yadav, Dr. Yadav, for all of this amazing information. And I'm just going to show us the tech whiz. So I wish I had jokes for you all. There it is. Perfect. Never mind. You've been saved by my jokes. So Effie, Effie Kosmas graduated. She's our next speaker, and she graduated with a Bachelor of Arts and Science in Health Studies from the University of Saskatchewan in 2021, followed by a Master's in Public Health degree from the University of Saskatchewan in 2023. Effie holds the role of Manager, Prevention and Policy with Lung Saskatchewan. In this position, she leads public education activities for the organization on threats to lung health and advocates for provincial policies that protect the lung health of Saskatchewan people. Additionally, Effie manages the Radon smoking cessation and no vaping activities for Lung Saskatchewan, and collaborates with various partners, including those with lived experiences, both provincially and nationally, in these spaces. A passionate educator and advocate, Effie's work supports preventative and upstream public health initiatives through programming, education, and policy. We can get a round of applause for Effie.
Hi, everyone. Happy to be here to talk to you all today. I'm with two other members of my team at Lung Saskatchewan. We have our CEO, Aaron Kwan, here, and our Director of Marketing Development, Deborah Keys. So we'll be available. We'll be around. We have a table set up. If you want to ask us questions that you don't want to ask right now, we'll be there to chat after the presentations too. So I'm delivering two different presentations today. The first one is on radon gas exposure and how that can impact your lung health. So we'll get started with this one, and then I'll also be speaking on smoking cessation or how to quit smoking following this presentation too. So first of all, what is radon? It's a question I get a lot. It's not something that everyone has heard of, but radon is a radioactive gas that's formed when uranium breaks down in the soil and rock. In Saskatchewan, we have a lot of uranium in our soil. We mine it here, so naturally we have higher radon levels. Radon is colorless, odorless, and tasteless, so the only way to know how much of it is in any home is to test for it. Health effects of radon gas, how this works is when we breathe in radon particles, which are probably in the room right now, the radon particles are always releasing energy. And when we breathe that in, that energy being released has the ability to damage the cells in our DNA over time. That can lead to an increased risk of developing lung cancer. So radon is a known carcinogen. There's not a lot of obvious biomarkers, but they have done extensive studies with uranium mine workers and just measuring levels of radon in people's home and seeing their lung cancer risk. And that is how we make that connection. Radon is the second leading cause of lung cancer after smoking, and it's connected to the deaths of 3,000 Canadians every single year. So as far as risk and prevention goes, it's dependent on three main factors. So the first being the level of radon that you're exposed to in your home. So geographically, Saskatchewan, like I mentioned, we have a lot of radon here. So just that alone, that increases everyone's risk in Saskatchewan. And occupation. So if you're a uranium miner, you're right close to the source, you have a higher risk of being exposed. Second is duration, time of life exposure. So somebody who has lived in a home all their life, from childhood to age 60, and they might get diagnosed with cancer, that is an increased risk just due to the long time period, versus somebody who's just moved into a home, test for radon a year later, and they have high levels. The third one, I don't know why it didn't show up, but it is smoking, just because that is already increasing your risk of developing lung cancer over time. So it's has a bit of a magnifying effect. But ultimately, the higher the radon level and the longer you're exposed, the greater risk you have of developing lung cancer over time. So how radon enters a house, because it's a gas, it has the ability to enter through any small crack, any opening it can find in your foundation, around the sub pump, etc. So because the air pressure inside of our home is lower than the pressure around it, the radon gas is drawn up like a vacuum. It wants to come inside the home. Things like windows, wood stoves, fireplaces, ventilation units, those can all also affect the pressure differential in different ways. But that pressure, like I mentioned, acts like a vacuum, draws radon in through those cracks. Then once it's inside the home, it really has nowhere to go unless your windows or doors are open. So that's when radon builds up to high levels. In Canada, there's no area of the country that's radon free. It's in every single building in Canada. Recent study just came out in October of 2024 that showed that around 10.3 million homes, or 20%, 1 in every 5 homes in Canada has high levels of radon. And by high, I mean that's a level that we're more concerned about the risk of lung cancer happening. But in saying that, there's really no level that's been proven safe. And we do always want to try to get the levels as low as possible through radon mitigation. Another important thing to note is that 2 houses built side by side can have very different radon levels depending on how your home is built, even what's in the ground right below your home. It all impacts the radon levels. Saskatchewan in particular, like I said, we mine uranium. It's a big export for us, so we have lots of radon gas. Saskatchewan has some of the highest levels in the world. Actually, 1 in every 3 homes have high levels here. Regina was recently flagged as a city with exceptionally high radon levels, with up to 1 in every 2 homes having high levels of radon. So the only way to know the level of radon in your home is to test for it. So Health Canada recommends doing a long-term 3-month radon test during the cooler months. So right now is the perfect time to test your home for radon. We're closing our windows and doors more, so radon has less of a chance to escape through any of those openings. We work with the Saskatchewan Research Council. It's a lab right here in Saskatoon. They do all of our radon testing for us. They analyze the test kits that we sell at our website, homeradontest.ca. So this is what the test kit looks like when it comes to your house. It's Health Canada approved, includes 2-way shipping, so it'll be shipped right to your house after the strike is over. And this is the test. This is all it is. So you don't have to do anything to turn it on. It's just plastic. There's nothing you need to do special. And then you'll place it inside of your home for 90 days, ship it back to the lab with the shipping label that's included, and then the lab will share your results with you via email. So it's very simple, very user-friendly. So why a 90-day test? That seems like a long time, but radon levels fluctuate a lot, even over one 24-hour period. So measurements that are gathered over a long period of time, that allows us to get the best accurate estimate of the radon levels in your home. And like I mentioned, building design, building condition, if you're opening and closing your doors a lot, that all influences the radon level in a home. Yes, question.
Do you recommend getting more than one? Because lots of the reading I've done, as we're exploring getting this done,
Sure.
like you should have one maybe beside your sump pump to check radon levels that are there, but also perhaps, you know, if your house
Yeah.
is bigger, or does the gas spread out equally throughout the airspace in your home?
Right. So typically what we say, if you're in like a condo complex, you would want to test maybe a few individual condos. But if you're in an average sized home that's not sprawling, you'll probably be okay with one test. And then having it, and if you're not spending time right next to your sub pump a lot, say, but I have worked with people who have, you know, their exercise bike in their furnace room or something, then you might want to test there. But otherwise, you put it on the lowest lived in level where you spend at least 4 hours a day. So if you have an undeveloped basement, I wouldn't even put it in the basement. If you are in the basement though, and you just want the level in there, even if you do laundry or just watch a bit of TV down there, I would put it in the basement. But usually one test is enough.
And I'm going to sound really cheap right now.
No.
But what's the discount code for it on the website?
I'm gonna share it and actually, yeah, for sure. Yeah, absolutely. No. And yeah, and if you are a lung cancer patient, I was going to share this too, but Lung Saskatchewan gives free radon test kits to people with lung cancer. So we have some available here today. So happy to distribute those after for sure. Yeah, so a little bit more on how to test, because that was a great question and we get lots. Where do I put this thing? We do have lots of details inside the test kit and on our website too when you get your test, but you don't want to put it next to any walls, doors, windows, and you want it at least 1 meter off the floor. It's affected by humidity, ventilation, and heat, so don't put it in the bathroom or in the kitchen. Choose the lowest lived-in level of your home where you spend 4 hours a day. So if you have an undeveloped basement, like I mentioned, you can just put it upstairs in your bedroom. That's a great place. But if you have an office downstairs or one of your kids sleeps downstairs, I would put it in their room in the basement. We also have electronic radon monitors. They're a little bit more expensive, but they kind of give you an instant read of the levels in your home. So these can be rented for free through various libraries in Saskatoon, Regina, and Moose Jaw for 3 weeks. They're also great if you want to buy one post mitigation to constantly be monitoring the levels in your home. But Health Canada, for right now, they approve these 90-day test kits, and I'll get to this in a few slides, but you need them for some of the available financial grants that we have for radon mitigation. So homeRadonTest.ca is our website. Lung Saskatchewan has designed it. Yes, it's a place to buy the test kits, but we also have a lot of information on radon as well, some common FAQs that we get. We have some people who have been personally impacted by radon and their stories available on there. And it is available in English and French as well. So when I say high levels of radon, Health Canada has set that level to be 200 becquerels per cubic meter. And that just means 200 radon elements are decaying every second. How this works is there's actually a very small plastic chip in here, and it counts the amount of time it's hit by an alpha particle, which is the type of radiation that radon gas emits. And in the lab, they can analyze that through a microscope and count the amount of times it's hit basically per second. And that's how they determine the level of radon in your home. But again, there's no known threshold concentration below which radon exposure presents no risk. You always want to try to get your levels as low as reasonably possible. Luckily, that is easy to do. There are 6 certified radon mitigation companies in Saskatchewan. They all serve various parts of the province. I think there's 2 or 3 right in Saskatoon as well. So this just means they have specific training in radon mitigation. Just to note that general contractors, plumbers, HVAC companies, they can all do radon mitigation. Anyone can do it, but they don't have that special training. And we have found that occasionally their prices are a little bit higher too. So if you do want to find a list of those 6 certified Saskatchewan mitigators, you can go to cnrpp.ca. Radon mitigation typically costs around $3,000, give or take, depending on the size of your home. So we definitely recognize that that's not super inexpensive for anyone. But there are two different available financial assistance programs for Saskatchewan residents if you are interested in mitigating your home. And how they do that, by the way, I'm sorry, I forgot to mention, but they install a radon fan and a radon pipe that draws the radon up and out of your home before it ever enters. And it can lower your radon levels by 90%. It can get it easily under 100 becquerels. So LungSask, we have a financial assistance program. All you need to do is use one of those certified mitigation experts, and we offer up to $500 for radon mitigation. The Canadian Lung Association, they offer up to $1,500 for radon mitigation. You do need to submit a quote before you do your mitigation, and you need a CNRPP certified mitigator and one of these tests, not the kind that you rent from the library, but that is available as well. So one of the last things I'd like to share is that at Lung Saskatchewan, we have the opportunity to work with some lived experienced lung cancer ambassadors. So this is from left to right here, Luana, Christine, and Carrie. Sorry, right to left. These are 3 women who have been diagnosed with lung cancer, and they do contribute their lung cancer to radon. And I'd like to share a video. This is Christine Elliott. She lives in Dundurn, Saskatchewan. We've been working with her for a few years, and she has a radon story. So I'm not sure how to share this video. Can I just click the screen here? Okay. Well, we'll make sure we get that shared after, or I can play it on my computer during the break too outside. But anyway, the key messages of this presentation is that exposure to high levels of radon for many years can increase your risk of developing lung cancer over time. People who smoke are at higher risk. The only way to know how much radon is in your home or workplace is to test for it, because again, you can't see it, smell it, taste it. You need to do a test for it. Radon concentrations can differ widely from one location to another, so you have to test every building. And if you have high levels of radon, they can be reduced, usually in a day. Mitigation is pretty quick. So like I mentioned, if you have lung cancer, we're happy to provide you with a radon test kit for free. If you'd like to buy one for someone else, sorry, the formatting got weird there, for a friend or family member, we're selling them today for $65. And we're doing $5 off, so they're $60 plus tax today. We do have other support groups available at Lung Saskatchewan. If you're interested, we have one for asthma, COPD, smoking cessation, which I'll talk about later tonight, sleep apnea, lung transplant, and pulmonary fibrosis. They're all virtual, but they're worth checking out if you're interested in them. We also have raffles. It's a great chance. We have some big 50/50s coming up, so those are always available too. Yeah, thank you for listening to the presentation on radon. Happy to answer any questions if there are any. Yeah. Okay, sure. Yeah, I'll play it in the background while if anybody else has any questions. Oh, yes.
You can go ahead and do that.
It's okay, it's not working, so.
I'm just wondering, does radon exposure lead?
That's a good question. It's one that they're still looking for the biomarkers for, just because, like I said, they have those studies that they compare it to. People who work in uranium mines have much higher risk, but they're still looking for those really specific biomarkers. They're even doing a study. They're asking people to send in their toenails to analyze them. But yeah, long answer short, they're still trying to figure out the exact types. It's a good question though.
My story began in August of 2020, initially with a diagnosis of breast cancer. And from there, we went into chemotherapy and surgeries and those sorts of things. In that time, we did find another cancer. And that cancer was lung cancer. And when I found out that I had 2 cancers, I was questioned, had I been in farm environments, had I smoked, and none of those answers were yes. And so at that point, the surgeon asked me if I had ever heard of radon, and I hadn't. And so I looked into it, and I learned that radon is an odorless, colorless, and tasteless gas it is present in many homes, and that we are somewhat of a hotspot for radon in Saskatchewan. Breathing in all that radiation all the time can harm the lungs over a period of time, and it creates damage and eventually can lead to lung cancer. I was introduced to Lung Saskatchewan, to radon, to the lung family, and they offered to test my home. And that's when I found out that it was high. And so from there, the only plausible answer was that it was a radon-related cancer. My stepfather, he was diagnosed with stage 4 lung cancer, and he did lose his life. It was scary and astounding that he had grown up in the same home that we grew up in. It was originally his home, and he was diagnosed, and then now 5 years later I was diagnosed with lung cancer. And so we had to kind of ask ourselves, what might be the common denominator here? And it was, in this case, the home. I was in remission after a year of treatment. Altogether, I did 5 months of chemotherapy, 2 surgeries, and finally 20 days of radiation. All in all, the targeted treatments were just about 2 years. It was an extraordinary moment to find out that I no longer have cancer. It was exciting, it was terrifying, it was beautiful, and it was all of those things. I remember ringing the bell in the cancer center and just being so elated, you know, that I was cancer-free and that I was gonna get an opportunity to live and to move forward with my life. And really, I think it was that day that I decided that I was just going to stop at nothing to bring awareness to radon and help people and try to make a difference. And so since then, I've written a book, and I've put a lot of effort and time into podcasting and trying to raise awareness for all different types of fears that come with cancer, and the awareness of what can cause it and all of those sorts of things. And it's just been a really beautiful life since then.
Much, Effie. We will be seeing Effie again for another presentation, and I'm happy to announce that at least the people virtually got to hear the whole presentation. So our next speaker is Shane Lalonde, and he was born and raised in the village of Marcelin. Am I saying that correctly? Okay, good. I was going to go very French on it, but it's Marcelin. Okay. And that's where he developed a deep connection to his community. Over the years, he has had a few careers and is a cancer survivor, with a belief that a positive attitude and support are the cornerstones of treatment. In 2018, Shane was diagnosed with stage 4 lung cancer, a challenge that set him and his family on an uncertain journey through treatments and the additional trials of navigating a global pandemic. Despite these obstacles, they emerged stronger and more resilient, embodying hope and perseverance. Now retired, Shane and his wife Linda cherish their time together, focusing on family, friends, and the simple joys of life. Welcome.
Hi there. In the village where I grew up, back then smoking wasn't seen as bad. In fact, it was cool, and the idea of cancer seemed like a distant worry. That changed for me in 1999 when my dad was diagnosed with stage 4 lung cancer. It was a shock. At the time, the only treatment option was radiation, and his prognosis was grim. His diagnosis, however, gave me and my wife, Linda, the motivation we needed to quit smoking. He passed away in 2002, and through his battle with short His legacy lives on in the choices we make to prioritize our health. In 2011, it was Linda's turn to face cancer. She was diagnosed with breast cancer and underwent surgery. Thankfully, they caught it all, and we breathed a sigh of relief. Fast forward to 2018, I had this nagging, annoying cough, wouldn't go away, followed me everywhere, including on a trip to Mexico. Linda's birthday rolled around that March. I wanted to take her on a special trip, and she refused to go until I got that darn cough checked out. And that's when we heard the words shook our world, stage 4 lung cancer. Hearing those words felt like time stopped. My brain got stuck on one word, cancer, and we still went on that birthday trip because life doesn't pause. When we returned, we started adjusting to our new normal. Our first meeting with Dr. Yadav was sobering. He spoke of advanced cancer and limited options, but mentioned the clinical trial I qualified for. That's when I learned something else about cancer. It comes with a whole new language, markers, immunotherapy became part of our vocabulary. I knew I'd throw everything at this disease. I started treatment with immune therapy and chemotherapy. Then I had to quit working, but we kept family gatherings and game nights as a priority, focused on living day to day. By November of that year, I began my first maintenance round. Unfortunately, complications with my pancreas led to my first hospital stay. We had to pause treatment. That pause allowed me to recover, and we celebrated the holidays the best we knew how. Family, food, and gratitude. After Christmas, I continued with different chemotherapies, treatments. Eventually, Linda and I returned to work for a while before deciding it was time to retire. Scans became a regular part of life, stressful, and consistently brought good news. The hardest period was during COVID. For everyone, it was a scary time, but for some of us with immune compromised, it was especially terrifying. Going to chemo treatments alone without Linda was one of the toughest things I've had to do. My last treatment was about 2 years ago, an immune therapy that kept my tumor stable and even smaller than when we began. There's something new on my scans. There's nothing new on my scans, I mean. And these days, my biggest health issue is kidney stones, which I'm gladly take over the cancer. What I've learned from cancer is that attitude matters, hope is powerful, and it's been a cornerstone of my journey. My family and I still have game nights. We have date nights with our kids and spouses. We try new restaurants and often end up at greenhouses. We camp, garden, and spend time in the workshop. Support system is invaluable. Don't be afraid to lean on them. Don't be afraid to plan for the future. As for me in the new year, I'll celebrate 7 years surviving. And just last week, I signed a 2-year contract for my new phone. Because I'm going to plan on stick around. Thank you.
Thank you so much for sharing with that. We are taking a break, about 45 minutes-ish. We're gonna get, we've got some refreshments and some food for everyone. So we will be back and we will have one more presentation with Effie after our break.
In your home, your car, even if you're not smoking, and children or other people in your family, friends are exposed to that can result in health consequences for them as well. So why is quitting smoking so hard? We'll look at nicotine addiction and nicotine withdrawal. And we'll look at the nicotine addiction cycle. So when we smoke a cigarette, your brain releases neurotransmitters, which is just a fancy word for chemicals that make us feel really good, really happy. So dopamine is a common chemical that nicotine causes the release of in our brain, which makes us feel really relaxed and good. That time between our last cigarette and the next one, our nicotine blood levels drop, and so does the nicotine levels, the positive, happy chemicals in our brain, those drop too. We'll start to feel sad, agitated, angry. And that is your body saying, I want more nicotine. And that's what makes you crave that next cigarette. And that's a hard cycle to break. Nicotine is one of the most addictive substances in the world. So it is a hard cycle to break, but it can definitely be done. So as I mentioned, nicotine is that addictive component of cigarettes. That on its own does not cause disease or death, but it's all those chemicals that are also contained in the cigarettes that do. It causes physical dependence and addiction. And so, yeah, like I mentioned, when you stop smoking, your brain and body begin to crave nicotine, and you'll crave that for a period of time. So when you try to stop that cycle of stop giving your body more nicotine, more cigarettes, you'll experience something called nicotine withdrawal. These are some negative symptoms that at first will feel really life altering, but they will go away. But it can be very hard to push through this initial period. It's typically the worst for those first few days in particular. You might experience just strong cravings, really wanting a cigarette. Weight gain. Nicotine suppresses your appetite. So when you stop consuming nicotine, you'll notice you'll be very hungry, just wanting to eat more. So you might find it hard to fall asleep. You might have a cough or quitter's flu, they'll call it, just feeling really, really down, not yourself. And as well as stress, irritation, you might feel angry. And again, you're not getting, your brain is now not getting the release of dopamine, that happy surge that it was used to getting. But over time, they will improve and your brain chemicals will balance out. So how do we defeat that nicotine addiction cycle? We can set ourselves up for quit smoking success. So I'll go over finding a quit buddy, the 5 Ds of nicotine withdrawal, identifying triggers that might cause you to want to smoke, and dealing with cravings that you'll get when you're trying to break out of that nicotine addiction cycle. So something positive that you can do for yourself is to find a quit buddy. So this doesn't have to be anything formal. This can just be somebody that you can talk to when you're craving a cigarette, feeling down, or you just need to vent, because it can be a hard process, and it's nice to have somebody there for you. It can be a family member, a friend, a coworker, someone who used to smoke, someone who's quitting smoking, someone who has never smoked. It doesn't matter, just somebody who could provide regular and non-judgmental support. This is also a quick acronym to remember when you're experiencing withdrawal symptoms to help you manage it. So delay. So when you're craving your next cigarette, really trying to put it off for as long as you can. It might be 5 minutes, it might be an hour. Setting a timer can really help just space your time out between cigarettes. Distract, doing anything else you enjoy doing. Go for a walk, play with your dog, do a puzzle, anything that keeps your mind off smoking that works for you. Deep breathing, just take a few minutes to focus on your breath, just slow down. Drink water also just helps you slow down and reflect and remind yourself that you can go without this next cigarette. And then 5, discuss. So talk to your quit buddy about what you're feeling, because often these are strong symptoms that you'll be experiencing, and it's helpful to have somebody there to be able to talk to you and work through it. And then identifying triggers. So triggers are anything that you associate with smoking or something that would lead you to want to smoke. And smoking is often tied to our daily routines. And we might not notice that until we actually go to try to quit smoking, but these routines can trigger the urge to smoke. It doesn't mean you need to give up your daily routine forever, but maybe during that first few weeks of quitting smoking, you might want to just change things up a bit. So some examples of this would be drinking coffee. That's a big one for people trying to quit smoking. They're just used to having a cigarette after their morning coffee. Drinking alcohol, socializing, that just might be an experience where you're just used to smoking. Relaxing after work, after eating, just part of your routine. Seeing cigarettes, so if you have cigarette butts in your car, in your house, in your backyard, you might want to clean those out just so that you're not tempted by it, seeing that. Talking on the phone, driving, feeling stressed or angry because nicotine has that calming effect with the dopamine release, but actually in the long term, cigarette use can increase feelings of anxiety and depression. So it's a bit of a false sense of security there. Seeing others smoking and particular hobbies, like if you're used to smoking cigarettes while you're fishing, that might just be something that you want to take a break from for a little while. And dealing with cravings. So cravings can be quite strong when they come on when you're trying to quit smoking. But when you reduce the number of cigarettes that you smoke each day, your brain will get used to having less nicotine in your body over time. You may get cravings to smoke, but if you resist and delay, they will become fewer, shorter, and weaker over time. There's 5-minute cigarette craving busters I have listed here. They can be really simple things: chewing gum, go brush your teeth, hum a tune, anything that takes your mind off of it. So the next topic I'll talk about is choosing a quit smoking aid. So there's quite a few different ones available, and different aids work better for different people, but I'll go over short acting and long acting NRTs. So that's our nicotine patch, and then nicotine gum, inhaler, etc. Going cold turkey, cutting back slowly. I'll talk about some medications as well, like cytosine and bupropion and varenicline. So NRTs, or nicotine replacement therapies, you don't need prescription for these by your doctor. You can walk into any pharmacy or Shoppers Drug Mart and purchase these. They're the safest way to use nicotine. They don't have any health effects because it's just the nicotine, not the additional chemicals. So there's long acting and short acting, which I'll talk about on the next slides, but using just one NRT can double your chance of successfully quitting compared to going cold turkey or using nothing. And using two together can triple your chance of being successful on your quit journey. So the only kind of long acting NRT that exists is the patch. So you might have heard of this one before. Nicorette makes them, some other brands do as well. What they do is they deliver nicotine through your skin as long as you have the patch on. You can keep it on for 24 hours. You can keep it on while you sleep. Some people don't like to because they cause quite vivid dreams. So you can take it off before you go to bed and put it back on in the morning. Patches often come in steps. So it kind of allows you to wean off of the nicotine over usually an 8 to 12 week period. Some people need less time, some people need more. But the overall purpose is to just lessen any withdrawal symptoms that you'll ever experience. And they cost around $25 a week to use. So for that 8 to 12 week period, so substantially less than cigarettes do. Now, you'll want to combine your patch with one of these short acting NRTs. So that's either gum, lozenge, inhaler, or spray. So you use these as needed. So while you're wearing the patch, say you just had your morning coffee and that has triggered you to really your craving for a cigarette. This is when you could chew a piece of nicotine gum, and it can really help improve your chances of quitting, again, up to 3 times if you use it in combination with the patch. Cytosine is something that's newer on the market. It's a natural health product. It doesn't have any nicotine, but it mimics the effects of nicotine. So it kind of tricks your body into thinking that you're still consuming nicotine. You don't need a prescription. This is just like buying the patch or Nicorette gum. You can just go to the pharmacy and buy it, and it helps increase your chance of quitting by 2 times. You can speak with your doctor to help figure out the right dose for you and if it's the right product for you. So there's also bupropion and varenicline. These are prescription smoking cessation medications. So you do need a prescription from your doctor or pharmacists. In Saskatchewan, we have almost 2,000 PACT trained pharmacists. So these are pharmacists who have been trained in smoking cessation, quitting smoking specifically, and they can prescribe it to you. So you don't even need to go to your medical doctor to get one of these prescriptions. But again, they really increase your chances of quitting successfully. You can also try cutting back. So this means slowly reducing the amount that you smoke over time. You can just try to skip every other cigarette. You can wait as long as you can until you have your next one, or you can just smoke half of every cigarette and then maybe a quarter of every cigarette and then just throw it away. Whatever works for you. Sometimes it helps to set a quit date and then work backwards. You know, this week I'm gonna smoke 3/4 of my cigarettes, and the next week half of each cigarette, etc. Whatever works for you. And then, of course, you can also try to quit cold turkey. So this means just quitting smoking without doing anything or cutting back. And it might result in more intense withdrawal symptoms, but again, those will fade over time. So preparing for your quit day. So quit day is a big day on your quit smoking journey. And I'll just review some of the things we've talked about and how we can make this day the easiest and go the most smoothly for you. So when you're setting your quit date, you're thinking about the day that you want to quit smoking altogether. You don't want it to be too far away that you lose motivation, but you want it to be close enough so that you are just ready to quit when that day comes. You also want to think positive thoughts. So before quitting, remind yourself that you can do this. Quitting is hard, but it's very possible to do. Reflect on your past. So think about how your previous quit smoking attempts have gone, what worked well for you, what didn't. Maybe the patch worked really well. And if it didn't, maybe this time you want to try prescription medications. The night before you quit smoking, feeling stressed, worried, or anxious, those are all normal feelings to have. Talk to your quit buddy, talk to a friend or family member, and remember that you can do this, but quitting is a journey. There's always going to be ups and downs. So quitting is a journey. Sometimes people can quit on their first try. Some take up to 8 to 11 quit attempts. That's all normal. Each opportunity is a chance to learn, and each attempt will bring you closer to your goal of quitting smoking. You'll learn things about yourself on the way. So in Saskatchewan, through Lung Saskatchewan, actually, we run a program called the Saskatchewan Quit Smoking Challenge. It's actually starting in 5 days. It's starting next Monday. So what it is, it's a Facebook support group. We have around 500 members. They're all living in Saskatchewan. It's a really positive group. People share their quit smoking journeys. If they have successfully quit smoking, we have people share those stories in the group. People who are trying to quit smoking, they share the kind of their day-to-day updates. And it's a really positive group environment. If you are somebody looking to quit smoking, it's a great resource. So this challenge that we run, we have weekly challenges to encourage people along their quit smoking journey. We share education and resources. We also give out free nicotine replacement therapy samples to everybody who signs up. So we give out free Nicorette patches and gum. We also share stories from ambassadors or people who have already quit smoking or people who are on their quit smoking journey. And we have peer support, and then we have the chance to win our $3,800 in prizes. So it is a great group to be in. Some of the positive feedback we had last year include, thank you, you gave me the courage to be smoke-free and I was desperate. Never in a million years did I think I could fully quit smoking. The group and support was a blessing in disguise. And then this person smoked for 47 years, tried quitting many times unsuccessfully. They liked the Facebook group because they felt like they were not alone in the struggle. Otherwise, in Saskatchewan, there's a few other resources in addition to our Sask Quits Facebook support group. Lung Sask has a helpline. So that's not just for quit smoking, that's for anyone. If you're a person living with lung cancer, COPD, any lung disease, we have 2 staff nurses on the line Monday to Friday, 8:30 to 4:30. If you have any questions, they're always happy to help you, answer them, or direct you to somebody who can. Smokers Helpline, Talk Tobacco, which is also the Smokers Helpline, but it's specific for Indigenous people. Métis Nation Saskatchewan also gives out free nicotine replacement therapy reimbursements to Métis citizens in the province. And then there's also the Quash app, which is just a great app to help you track your quit smoking journey. And that is my presentation on smoking cessation. So thank you. If there's any questions, I can answer them, or feel free to meet me out front after too. Yes. Yeah, that's a great question. We get it a lot. So, oh, sure. So you're asking if vaping products are basically approved for smoking cessation as a method to use. Yeah, so by Health Canada, no. So that's what we go with, is that they're currently not approved. Having said that, we work with some people and vaping has helped them quit smoking. So that works for them. But at Lung Sask, we would really support the use of nicotine replacement therapies or the medication, quitting, cutting back. We wouldn't recommend vaping as something to try, just because it's still delivering nicotine in addition to the chemicals that are included. Many of the chemicals in vapes match the chemicals in cigarettes, which we know are carcinogenic. So while we can't make that link directly yet, because vapes are so new, there's still so many new studies being done. But we can make the connections and see that we don't want some of those chemicals in our body. Thanks. Thank you.
Thank you so much, Effie. That was brilliant. So we have our next speaker is Alemania, born and raised in Saskatoon, and he was diagnosed with ALK positive lung cancer in 2020, a life-altering moment that redefined his path. A graduate of the University of Saskatchewan's kinesiology program, Alan is currently completing his post-degree Bachelor of Science in Nursing. This diagnosis became a catalyst for resilience and personal growth, inspiring Alan to focus on equitable healthcare, particularly for marginalized communities such as 2S LGBTQIA+ individuals and immigrants, driving his future plans to address systemic inequities and improve health outcomes for underserved populations. Alan, take it away.
Good evening. My name is Alemania. Before I begin, I'd like to thank the organizers for having me here today, Dr. Yadav for recommending me, and my family and friends for coming tonight to support me, and all of you for your patience, as I'm not the most experienced public speaker, especially since I only put this together this week. So, like what was said before, I'm originally from Saskatoon. I studied kinesiology here at the University of Saskatchewan, where I was also on the USAS cheer team, and I'm now finishing my second degree in nursing. In 2020, I was diagnosed with ALK positive lung cancer. As for my spare time, though, if you're familiar with nursing school, you know there's not much of it. I'm part of 2 dance crews. A big shout out to OD&T and Flip Kids, and I also enjoy practicing wushu. I want to take a moment to acknowledge the land we are on. As we gather here today, we acknowledge we are on Treaty 6 territory and the homeland of the Métis. We pay our respects to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. Indigenous people were and are talked about in the past tense, and all the struggles they faced were talked about in the past tense as well. It is easier to deny Indigenous people their rights if we historicize their struggles and simply pretend they don't exist. As an advocate, I would like to take this opportunity to commit myself to the struggle against the systems of oppression that have dispossessed Indigenous people of their lands and denied their rights to self-determination. This work is crucial to human rights efforts globally, impacting not just our Indigenous communities here, but also around the world. Tonight, I would like to read you all my love letter to the one who took my breath away. To the one who took my breath away. I remember the first day we met. I was only 19, and it was a cool winter's day. You were a ghost in the night. I did not know you by name, but when I woke up, the only trace of you was the blood on my lips and a cough that carried questions with no answers. I searched for clues for you everywhere, my search leading me to St. Paul's Hospital, where I spent 10 days desperately trying to find answers, enduring even the harshest conditions, hospital food, the hospital halls, only leading me to false answers and dead ends. The only clues that I found were laced in my lungs, evidenced by only pictures, where you left traces of yourself littered throughout, yet I still could not put a name to your face. My search for your name continued for another 5 months, where I knew I could not rest until I could finally face you properly. You affected me more and more each day, where I could feel you in every breath I took and every cough I made. Along the way, I crossed paths with countless nurses and doctors, guiding lights on my journey, and endured many tests and trials in pursuit of the truth. Each day was agonizing, not knowing who you were, but knowing you were so entwined with my body. My curiosity was finally quenched when, One spring day, 3 days before my 20th birthday, I finally learned the truth. The memory was still so vivid. Waking up to a phone call that morning where the doctor whispered your name so gently, lung cancer. To quote Ocean Vuong, sometimes being offered tenderness feels like the very proof that you've been ruined. To be quite honest with you, you are not who I wanted it to be, but still, relief flooded through my body, a striking contrast to the fear and anxiety ripping through my head. A name has never held such immense power or stirred such deep emotions. In that moment, it struck fear, inspired courage, and ignited love. Your arrival in my life was far from the fairy tale ending I had hoped for this mystery, yet it became the beginning of one of my life's greatest chapters. In the beginning, you were a presence I wished to avoid, a shadow unwelcome in my world, a sentiment echoed by both friends and family alike. But you were clingy and more intertwined with me than I thought. Later on learning, your very being rooted itself not only in my lungs, but entwined with my spine and nestled in my brain. I was reminded of your presence with each breath, movement, and thought, a stark reality that made me feel like you would never leave. Our relationship was toxic. Your attachment to me was purely physical, invading my body like a parasite, feeding off my energy and leaving only destruction in your wake. You were exhausting, both on mind and body, your presence seeping into my soul, leaving me drained and incapable of sustaining any task for long without feeling utterly fatigued. You stole from me the passions that once set me free, the beloved spring floors where I soared with boundless joy. You have anchored me to the ground, clipping my wings of freedom. You would not let me laugh with my loved ones, interrupting me with a cough that would echo through the hollows of my chest and ring through my ears, making me wonder if I will ever truly be happy again. I felt constrained. The thought of you loomed over me, a beast so big, I felt so small. My identity covered by the immense shadow you cast. When can I speak your name and let it be only a name? You loved me for what I could give you, but I hated you because you took and took and took without giving back. At least that's what you made me believe. But I was not alone in this fight against you. My family and friends became a steadfast force that refused to let me fight this battle alone. Their unwavering support wrapped around me like armor, shielding me from despair and giving me strength on days when I felt weakest. Each day, their love wrapped around me, a constant current of strength, reminding me of a resilience I often doubted. Their whispers, if anyone can do this, it's you, or you're the strongest person I know, lifted me higher, even as the weight of imposter syndrome tried to pull me down. They reminded me of the person I was beyond this illness, the laughter we shared, the dreams we still planned to chase, and the strength I had forgotten was mine. For every hand that supported me, the other helped lay each brick of my resilience until I built a castle where I was the king and you were left outside, your whispers silenced, powerless to breach the walls of my mind. Meanwhile, doctors and nurses were relentless in trying to find ways to weaken your hold on me. They armed me with their bullets of healing, a weapon designed to target your grip and cut off the very pathways you used to thrive inside me. Each pill became a step toward reclaiming my body, a daily act of defiance against your relentless invasion. Their care went beyond medicine. It was a lifeline, tending to my body, mind, and spirit, and reminding me that you didn't define me. Together, this team of healers and loved ones helped me write a new chapter, one where you no longer held the pen, and they transformed the story you tried to write for me and gave me hope when I thought I had none. With every small victory, I began to see a future beyond your shadow. Up until now, I saw your power over me as purely destructive, but for there to be a shadow, there must also be light. And in your shadow, I found a brilliance I never expected, the light of deeper connections with my family and friends, stronger than ever before. You forced me to discover resilience I didn't know I had, a character forged in the fires of the struggle. The strength you forced me to uncover left me strangely grateful that you chose me, for if it meant sparing those I love from ever knowing your name as I have, picking me as you have, I would have endured 1,000 lifetimes with you without hesitation. So, this is my first thank you, not for the pain you caused, but for the clarity and strength I gained in spite of it. You brought me closer to those who matter most and helped me uncover the power within myself to stand tall, even when your presence loomed large. It was through this battle that I found the light you never intended to give. My second thank you is for the unexpected gift you gave me. Though you took away my ability to fly, I discovered new and old passions that gave me purpose once again. I found a new sense of freedom, losing myself in the bass of the music, letting my body sway to the rhythms that echoed the beat of my heart. You pushed me to rediscover my love for dance, a way to make the lungs you held captive move once more. Although I felt the remnants of your occupation in each shallow breath, my defiance of you drove me to push past my limits, pushing my stamina 1/8 count further, 5, 6, 7, 8, each step of victory over you. With every breath, shallow yet fierce, I defied you, my body swaying in protest, reclaiming what you tried to steal. I danced not just to feel free, but to remind myself that you would not break me, no matter how tightly you tried to grip. My fear of you sparked a courage I never knew, a realization that life is too fleeting to waste. It was this path that led me to wushu, where strength and grace became my rebirth, each punch and kick a tribute to you, my body alive with new strength. My weapons became my truth, each slash of the sword cutting through your grip on me, each thrust of the staff pushing you further away as I reclaimed what you tried to take. You unknowingly led me to 2 new families, each a world of their own, whose hands joined those already holding me high, lifting me ever further beyond your reach. Thank you. The day I learned you finally left me was one of the happiest days of my life. I know you wouldn't want to hear that, but it's the truth. My family and friends rejoiced, their hearts lifting as they knew the relationship you imposed upon me would no longer haunt me. Each breath I took from that moment on would be my own, not shared with you, no longer tainted by your shadow. The air felt different, lighter, freer, as if the world itself had exhaled a collective sigh of relief. And for the first time in months, I could breathe deeply. My journey in finding you has led me to cross paths with many healthcare workers, each one respectable in their own right. And to all of them, I am deeply thankful. But it was the nurses with their boundless empathy and unwavering care who left an indelible mark on me. Their presence, compassion, became my anchor in the storm. It is the same comfort they gave me that now drives me to follow their path, to offer that same healing touch, to be a beacon of hope for others in the darkest moments. The art of patient-centered care, where every action is rooted in understanding and compassion, has become my guiding light. I long to emulate that deep connection, to be the kind of caregiver who sees not just the illness, but the person beneath it, to listen, to truly hear, and to care with heart and soul. Yet, as I stand on the edge of this path, I hesitate to thank you, for if you truly understood the horrors of nursing school, you would know why. However, that doesn't outweigh what I found in nursing school: a family, lifelong friends, whose bright minds mirrored the brightness of their souls, illuminating my journey. Together, we faced challenges, celebrated victories, and shared dreams. Their unwavering support, their laughter, their brilliance reminded me of the beauty in human connection. And so, lung cancer, I thank you. For it is through the pain and the trials you brought into my life that I discovered these truths. You forced me to see the value of empathy, of human connection, and of the kind of care that heals not just the body, but the spirit. Without you, I might have never found this path. It wasn't long ago that I received news I never wanted to hear. a cruel reminder that the past has a way of echoing through the present. The whispers of old wounds seem to mock me. Winter, they say, is a harbinger of death, and it had once again killed my hopes. The words, heavy and cold, telling me that the bullets of healing weren't hitting their mark, that you, once driven back by this bullet fire, were finding your way back into my life. The news shook me to my core. The drive home was a frozen silence, broken only by the sound of my tears, the hiccuping cries of someone trying to find air and a suffocating reality. I resented you, resented the way you tore open old scars and made my family and friends feel that pain once again, as you threatened to overtake my body. I hated how you made them watch, as you tried to claim everything I had fought so hard to keep. But even the harshest winters cannot last forever. The snow will melt, and so too did my worries. For though you had tried to return, you had left me a castle that I still stood on, and a support system that anchored me when I thought I might fall. As I cried on that ride home, in the silence between my sobs, I had a revelation, an understanding that would forever shift the way I saw us. You were not some distant, separate enemy. You were not something apart from me, lurking in the shadows. No, you were woven into the very fabric of my being. You were me, and I was you. No matter how twisted or painful it seemed, we were born from the same place, the same cells, the same lungs that provided oxygen to my brain, fueling me to study, to learn, and to pursue my calling as a nurse. The lungs that fuel my body to move, to dance, and to practice wushu, reminding me that I still have strength in places I thought you had stolen from me. You are not separate from me. You are a part of me, woven into the essence of who I am. And in that realization, I found the strength to stand once more as one. With the unwavering strength and conviction forged in the fires of my journey, I have arrived at my happy ending, a place where new treatments were found, offering hope for healing. The resilience I cultivated carried me through, even as I underwent radiation, fitting in treatments between clinical lunch breaks, and finding new pills that worked, even if they caused me to gain weight. But what good relationship doesn't make you gain weight? Yet, my true happiness does not lie in your removal and in extracting you from me. No, it lies in the acceptance that you happened. Though your name once carried the weight of fear, the path I walked with you taught me invaluable lessons, lessons that reshaped me, that deepened my understanding of life and myself. You, the shadow that loomed over me, ultimately helped me become a better person, and for that, I'm grateful. I've always thought since meeting you, could I ever find love, knowing that part of me is borrowed time? Is it selfish to allow someone to love me when I carry the weight of this illness? To offer my heart, knowing it might one day be taken away, feels like a risk I don't want them to bear. But in the quiet moments, I wonder if love isn't just about time, it's about the moments we choose to give, no matter how fleeting they may be. And even if I don't find that love in another, I've discovered the greatest love story of all time within myself through this journey, one that has taught me the value of my own strength and worth. So I will always remember, though lung cancer has shortened the number of breaths I take, every inhale still carries with it the same hope, and every exhale holds the same dreams as anyone else. In the end, it's not the number of breaths we get, but what we do with them that truly matters. To quote Pablo Neruda, I love you as certain dark things are to be loved in secret between the shadow and the soul. Yours truly, Alemania. Thank you all for listening to me tonight.
Whew. Way to bring the house down. Thank you. Wow. Thank you all for joining. What a brilliant evening. I think it pulled all of the strings in here and in here, so thank you very much. If you are looking for more information on Lung Cancer Canada, or if you'd like, we've got English ones, I'm assuming. I just grabbed this. I just grabbed a guide here, complete guide to lung cancer. You can grab a copy over here. There are some in French as well. Or if you want a pamphlet on Lung Cancer Canada, if you'd like any more information, please come to us. I think there's an incredible wealth of knowledge and amazing heart here. So please take advantage of that. Thank you so much for joining and have a great